if you look back here, let's see. This is kind of in the scarring alopecia section here. So it's one that we would maybe see in pediatrics. Again, a lot of these things kind of tend to be more adult stuff or teenager stuff. The dissecting cellulitis obviously is fairly scarring. And then also this kind of odd like papular appearance that causes alopecia. I feel like I actually did have a kid at chalk with this, and like I looked at it and the attending looked at it and none of us knew what the heck it was. But now that I saw this picture, I think that may have been what it is. So could be a good thing to at least be aware of kind of these like larger papules. And of course, both of these two images are in an African-American patient. They're more common in African-American patients. And then some non-scarring things, the loose anagen syndrome, much more common, basically like super fine blonde hair. And then this is that weird genetic syndrome where these kids have no hair and they have papular lesions, and it is an autosomal dominant condition. So maybe you know something that Stallworth doesn't know. Maybe he already knew this. I don't know. Back to the patient. So about that acne, it's on her face as shown. She got acne when she started her periods around age 11, and it responded well to benzoyl peroxide. However, now that it's back, she doesn't feel like it's really responding well to the benzoyl peroxide. So y'all were asked to, again, describe the skin findings, and I would say that y'all did a pretty good job. So we're talking about the color and the pigmentation, which is fantastic. And then talking about it, being dry, and kind of the scaling that you see is really good. And I think it's the important thing that I wanted to kind of draw out here is just noting that it's not just like redness itself. It's not like what Dr. Dingle was referring to, someone like goes outside for too long and their cheeks are kind of red, or they just finished running or something like that. Then I think that kind of noting that it spares the nasolabial fold is right on the money with this malar rash. I think y'all did a good job. I don't have anything really negative to say with these responses. I wanted to take a second just to talk about some important mimics. I tried to, point out that it could look like acne just to make it a little bit more tricky. Things to also consider if you see a rash on the cheeks are going to be acne, obviously. So what I have here is the first picture is malar rash going, first column, I should say, is malar rash. Second column is acne. Third column is rosacea, which sometimes kind of can be a type of acne in some ways. And then last one is just parvo B19, because that's another redness of the cheeks thing. So they all can look quite similar, really. I tried to kind of differentiate also like darker skin tones and then lighter skin tones. Something to look back at maybe and just, recognize that they can look pretty similar. And so the next question was, if present, which of the following raise your suspicion for lupus? Let's see. So a couple things to notice for her. We got to have a score of at least 10. I would say that from what we know so far, she has both the down here in the mucocutaneous section, the subacute or discoid, and then also she has the acute cutaneous. The way that this particular scoring works is that you pretty much have whatever point is the biggest in the group. So she gets 6 points for that. And then you could also think about fever, which was one of the options for what would raise your suspicion. I think that one of the other options was acute pericarditis, and then also joint involvement. So if you got all those things, that would be definitely more than 10. And I think I put the appendicitis one too. Initially, when I wrote the question, I had having a cholecystectomy in the last year, and Dr. Dingle pointed out that you actually that could potentially fit if you kind of go from like a autoimmune hemolytic anemia type of standpoint. So even that could technically be something that would make you think about lupus. And then I later on I put in that you could get a renal biopsy for the labs. I just also wanted to just highlight that this gets you kind of the most points out of all the things here. But obviously we don't jump to renal biopsy. So these were y'all's answers. Nobody ended up putting history of nasal ulcer, which is interesting. I think that most of these responses were before Dr. Dingle's lecture on Wednesday. But that's a good thing to remember, is just history of nasal ulcer, especially since these are painful. If there is something like, oh yeah, her pediatrician did notice that something looked weird in her nose before. Something subtle like that certainly could be more significant than you realize. Fever was one of the right answers. Admission for pericarditis, of course. And then I think that a lot of y'all took the bait for sun exposure worsens with symptoms. It looks like 6 of y'all answered that. And so sun exposure itself worsens symptoms, but the part that's incorrect is the within 1 hour. It's an immune response, so it takes longer than an hour for the sun exposure to lead to the worsening of the autoimmune condition. From what I read, at least, I think that the average was actually about 2 weeks out from sun exposure, and it could be even longer than that. So it's not necessarily something that the patient will like readily identify, just because that is so far out from when they actually had the sun exposure that it might be hard to correlate that. And then of course, a lot of y'all got the swelling of 1 knee and 1 wrist, which is fantastic. All right, and then what's up with her toes? And I think Dr. Dingle, if you are on the line, you may be able to better address some of these things. Kind of comparisons to some other vasculitic type things. So please speak up if you are able to. It looks like some people kind of brought up like Osler nodes and Janeway lesions. And then otherwise, I think that y'all did a pretty good job of kind of describing as well as possible basically what she has here, which is vasculitis.
Yeah, so this is a pretty classic appearance of digital vasculitis in lupus, but of course would be similar to other lesions from vasculitis for lots of reasons. Say HSP, or a patient with granulomatosis with polyangiitis. So I think your descriptions of, erythematous or violaceous macules, of course, this would be one that if you could actually see them, it would be important to say if they blanch or not, because lesions from vasculitis would not be blanching and would be kind of more in the purpura category. I would not describe this. So this does not look like Raynaud's phenomenon to me. In Raynaud's, you get more of a clear line of demarcation with a color change distal to that point. So not all color change of the extremities is Raynaud's. Yeah, so great. So for whoever was asking if they blanch,
Yes.
That's perfect.
Perfect. Thank you. And I think, so here's just a couple more pictures of vasculitis. I think these kind of look a little bit more classic. I tried to get different skin tones. And then some of them are kind of more of like the palpable purpura type appearance, and some of them are not quite so palpable. I think that some of these things, the more that you see, the better, because I feel like they all can look a little bit different, and sometimes they're a bit more subtle. And then I also have exactly what Dr. Dingle was just talking about. So Raynaud's, what it is and what it is not. So Raynaud's here, this picture on the left, we have nicely well demarcated kind of several different fingers, whereas the two pictures on the right are normal hands. There's, maybe a little bit of redness in the fingers here, and probably this person feels cold. They're somewhat pale, but this isn't really well demarcated, and so not likely Raynaud's. And then same with this person. There's not really any like well demarcated areas. It's just kind of a normal hand. And then this is really interesting to see these results, and I, in some ways, kind of put this question in out of curiosity of what everybody else would say. So in this question, your attending gives you free rein to order whatever labs you want to continue the workup while the rheumatology referral is pending. What do you want to order today? First off, thank you for nobody putting kidney biopsy. And then otherwise, I think that, really none of these would be wrong answers other than kidney biopsy per se, but I think that it's fantastic that most people kind of went with some of the like more measures of like function and like organ involvement and whatnot versus just like everybody putting ANA. Dr. Dingle.
Sorry.
No, I'm interested to hear what you have to say about all this.
Yeah. This is a patient, she has a legit malar rash. She has lesions that look like discoid lupus. She has vascular rash. Like, I'm okay if you order an ANA on this patient. I promise I'm not the ANA police. But I like that Jessica put on here the different kinds of ANAs that you can order because it's kind of confusing. So it's nice to have both the titer of the ANA to let you know how high it really is, and also that reflex panel that'll give you things like double-stranded DNA, Smith, RNP, SSA, SSB, because if it's positive, we're going to want all those results for sure. And then my typical approach would be, you've got to get a CBC to look for any cytopenias. You need a CMP to check things like liver, kidney function. Definitely get a UA. And I do usually go ahead and get the protein creatinine ratio to see if they have true proteinuria, if I'm really suspicious of lupus, because that's one of the most common things you're going to find and one of the things that will really dictate your treatment to begin with. SED rate is helpful. CRP, like I talked about in my lecture, is not always elevated in lupus and usually isn't actually. So less helpful probably. Rheumatoid factor is probably not helpful in this case. The only time it's helpful is if you're specifically have a patient with isolated polyarthritis to kind of see what category of JIA they fit into. Phospholipid antibodies, I think, are a good idea, especially in this patient who has kind of these digital vasculitic appearing lesions, and complements will be helpful too. ANCA, I would maybe go after if she did have more like pulmonary symptoms, if the renal biopsy, once we got to it, was more concerning for that, but things really seem more lupus-y than ANCA vasculitis related at this point.
Thank you. All right, moving on to little Wanda, our 6-year-old female who won't walk. You examine her joints and you don't really appreciate any effusion, but you do notice a rash on her fingers, which is pictured in the top 2 images. The second one was zoomed in for detail, and then this question stem got cut off. Basically, after looking at all these things, you are like, shoot, I'm not sure what this is. And so you excuse yourself to kind of pause for a moment and think, and you go to Google and you type finger, knee, and then which of the other following terms. It's kind of a silly way to ask, but I think y'all did a good job as far as just identifying, again, erythematous, violaceous, and then, kind of differentiating that this would be papules and not, vesicles or pustules and things like that. I think, obviously in a 2-dimensional image, it's hard to say for sure if things are papules or macules, but it would be pretty hard for like especially the zoomed in picture of the finger to be anything other than like three-dimensional and, you know, not completely flat. And I think I could see saying skin colored, but really all of these areas are kind of erythematous. And so I tested it out. If you typed in those words, you actually would pretty quickly get to juvenile dermatomyositis. So then the other question that we had, let's see. Oh, I didn't put it. 1 second. The other question that I had was, what would y'all, what other things would you expect to see with juvenile dermatomyositis? And so here are your responses. You can see, so the options were calf muscle pain, Gower's sign, proximal muscle weakness, heliotrope rash, psoriatic rash, normal CK, tongue fasciculations, nail fold capillary changes, dystrophic calcinosis, and then mental retardation. I think that for the really, really classic ones, pretty much everybody got it right. So that proximal muscle weakness and the heliotrope rash are like, you know, I think that, you know, obviously everybody or a lot of people got them right. And that's like the classic things that we want to think about for juvenile dermatomyositis. The nail fold capillary changes, I think, especially if you've worked with Dr. Dingle, you know, you may start to think more about this kind of thing. And that is absolutely one of the big things with juvenile dermatomyositis. The things that people weren't quite as sure on was the dystrophic calcinosis. And this is not something that I think we learned quite as much in medical school, but it is an important thing that happens in dermatomyositis. And then also Gower's sign. I know that we think about it for other like neuromuscular kind of things, but you could actually see Gower's sign if you think about it because of that proximal muscle weakness. So going back to these slides. So things that are not commonly seen in juvenile dermatomyositis that I put as options. Calf pain. Y'all know Stallworth loves this one. It's more consistent with viral myositis, especially flu. He loves that association. Psoriatic rash. That would probably be atypical for JDM. I know that there are some other rashes, like you can still get malar rash, I believe, in juvenile dermatomyositis, but psoriatic would be a little bit odd from my understanding. Normal creatinine kinase. If you had a normal creatinine kinase, but you were otherwise thinking about JDM, you'd probably want to think about other causes of muscle weakness, like neurologic dysfunction maybe. Tongue fasciculations, this is kind of more associated with SMA. Given that this patient is age 6, it would be one of the more mild types, so like less copies. And then mental retardation, again, mental retardation in a patient with muscle weakness, that combination would kind of make you go more for like metabolic disorders more than like autoimmune. And then heliotrope rash. So again, the important thing to kind of be able to distinguish it from is just eyelid eczema, because that's actually a place that, especially for like the teenagers, you can have eczema of the eyelids. And the important thing is just that it's not necessarily flaky like eczema would be. You can see those capillary changes other places also, like the gums and the eyelids. And one thing to really be mindful of for a kid who you really, really think might have juvenile dermatomyositis is, you know, that if it's involving any sort of like swallowing function or airway protection mechanisms, then you would maybe want to admit them for that reason. Same for, you know, if you thought that you needed to work up other causes kind of more urgently, then that might be a reason. I think that that's my last slide. Dr. Dingle, do you want to say anything else about juvenile dermatomyositis?
Nope, I think that was a great overview.
Thank you.
Come have her in clinic and I'll show you more.
Yes, yes. Very good. I decided to just choose my very favorite joke from the ones that y'all submitted this week. So it was, time flies like an arrow, but fruit flies like a banana. And that is what I've got. I think the next Physical Findings Friday, I can't remember when it'll be in May, but I believe Scott and I, since we are on Picky right now, we'll be maybe talking with Dr. Ricker about some kind of emergency type things, because I think that that's what a lot of the lectures are related to next month. Dr. Dingle, thank you so much for being here for this lecture, or this kind of talk about these questions.
Anytime.
All right, thank y'all so much again for your responses. The whole point of this is kind of to have a conversation about these things and to kind of learn through trying. So thank y'all so much again for participating.